Okay, welcome back to Parenting for the Present, where we explore the intersections of science, psychology, and family. Today, we're joined by Dr. Natalie Crawford, board certified reproductive endocrinologist, podcast host, and author of the soon to be released book, The Fertility Formula. Her work empowers women to understand their hormones and fertility, not as mysteries, but as formulas rooted in science and self compassion. This episode is for everyone because every woman and their partner at every stage deserves to understand her body. Whether you're trying to conceive, walk through infertility treatments, have completed that journey, or you're navigating perimenopause or menopause while raising those teenagers, this conversation will speak to you. I am personally very, very excited for this guest, Dr. Natalie Crawford. I first met Natalie in 2019 when I was working on a fertility fraud bill in Texas. And for those listeners who don't know my personal Jerry Springer Maury story, you can actually listen to Dr. Crawford's podcast as a woman when I was her guest. So, Dr. Crawford, thank you so much for coming to talk with us today. What inspired you to write this book, The Fertility Formula?
Well, thank you so much for having me. And I'm so honored to be here with you guys. This book is honestly, I went through my own infertility journey as well. And during that time, I was an OBGYN resident and a fertility fellow. And it was so surprising to me how the questions I really had, nobody had answers to. And then to be on the side of being a patient, it was quite eye opening how when I asked these questions to my own doctor, how dismissed and I felt. And I think it's something that especially when you're in training, you're going through, you're always triaging how urgent a problem is or what it's like. But to be in the shoes of the patient and feel like something's wrong with me and then be told, no, just relax, keep trying, no big deal, really felt it's just one of the worst feelings because you felt so out of control, this loss of self when it comes to infertility and wanting to understand your body. And it's just something that women nowadays, we're not taught. We're not taught about our cycles. We're not taught to track them. We're not taught what influences them or what red flags even are. And so walking through my own infertility journey, going through fellowship, doing my own research, and I was very snotty in a way that I wanted to do my fellowship research. We do a year and a half of research in REI fellowship, and I want to do it on natural fertility and not IVF. And most people do an IVF project. It's easier. It's in the lab, that I really wanted to study natural fertility and a lot of the things that impact your ability to get pregnant or your cycle or your hormones. And I was lucky to do this and I got a master's in clinical research, but I really realized I saw the word inflammation everywhere. I saw a lot about how endocrine disruptors, about how the foods that we eat really can impact a lot of our hormonal health on a day to day. And then I just felt like I sat across for women and men for years who really this idea of egg quality and sperm quality and hormone health are things that nobody is paying attention to. And they really felt like the answer was, oh, just do IVF or don't worry about this. But even when it comes to IVF, we can only work on we can only use the eggs and sperm that we're given. So if, we're giving eggs and sperm that are not the best quality, we can't do magic in the lab. So it became this passion project of mine to help educate people and kind of bring that knowledge base up so that they could even have educated discussions with their own doctors, with themselves, to seek care earlier. And that was really why I started even talking on social media about fertility, started the podcast. And then the book is just that way to give it to people in a easier format because so much of this, in health and in medicine, topics build off of other topics. And it's really hard to get that in a 60-second clip on Instagram and really understand what PCOS is. And so to really help level the playing field, to say this is the knowledge we should have learned, these are the red flag warning signs and what you should be asking for and what you should do about this if you are trying to, understand your body better, but then really to dive into all these factors that we make choices every single day that impact our bodies and how our cells work and our hormonal health, and how we can start to leverage that in our benefit to optimize our hormones and our eggs and sperm quality versus not. And so that's been a huge passion of mine. I've worked on the book for years and years, and I'm so excited that it's finally coming to fruition and coming out in the spring, because I think that it's really going to be something that helps put the power back into the hands of people. Say, I want to control this. And what can we do is we can understand more. We can know how to advocate for our own health, but we can also know how the things that we're choosing to do or not do can influence that.
I think it's super interesting just the multiple things that you look at in the book in terms of emotional factors, food factors. Uh, it seems overwhelming to think about all the different reasons why people may have infertility. So I'm curious how you broke that down.
It's a great question. I think when it comes to thinking about infertility, there are so many different factors, yet there's so many things that can impact all of it. So I think one of those big core concepts is inflammation and how inflammation can impact how your cells function, can impact the quality of the DNA inside eggs and sperm, but can also impact, right, hypothalamic interpretation of hormones, how your body interprets and sends out hormonal signals, how that comes back to your gut health and to insulin resistance. And classically, these are topics that many times we kind of have deemed too complex for patients to understand. And it's been like, oh, here, just do this to help this versus breaking it down. And in the book, the first chapter is about inflammation, how it, wreaks havoc on your hormones to really lay the ground stage that a large reason why we see an increase in infertility now than we saw a decade ago is also we're seeing an increase in inflammation, inflammatory diseases, and we're seeing an increase in autoimmune disease, environmental toxins, decrease in sperm counts, and that this is not just coincidental. A lot of this is the world that we're currently living in and how it's setting us up for failure. And then breaking down to what should happen normally. So we've got, what should happen with your menstrual cycle, what your hormones do normally, what happens with your ovaries and ovarian reserve normally. And then going through what happens when things are off, different stages of period abnormalities. What is the basic fertility testing and what you should be looking for and going through? And then going through when you try to get pregnant, what you should do, and when you have IVF, what you should do. But then really tying it all back to that inflammatory concept when people say, well, what can I do to make a difference? This is where, half the book is going through kind of what I consider the foundation of your day: sleep, stress, and exercise, like choices we don't even think about that are setting the stage for how much inflammation you have. The
You sound
food.
like Matthew Hausen with that one. He's always like, it's because you don't have enough sleep.
I mean,
So
but
he's
it's true.
excited about that one.
I'm the sleep guy. Yeah.
Yeah.
We've normalized not having sleep. People are like, I only need 5 hours. I mean, how many times do I
Mhm.
hear that from my patients? And I say, you may be able to survive on 5 hours, but you're paying the price for it somewhere else, right?
And I think
But
that's
then
interesting, just tying it back to inflammation, right? And how those underlying factors do things internal to our body that people aren't aware of. So I think that's super interesting, the concept.
And then talking about from inflammation, dietary, how right diets high in fruits and vegetables and fiber, how that helps your gut health, decreases inflammation, how processed foods can be detrimental to this, and then environmental toxins. And it's really interesting because I used to not always frame it this way. And I would just say, these are the foods you should eat and these are the things you should do. But I have found that universally, when you give people the benefit of the doubt and you explain the science of why you're recommending something, they are going to be 100 times more likely to implement that change once they start to understand, oh, well, that makes sense. And oh, I never thought about it that way, that, this is actually what's happening to my body, and trying to make it easier. And the book does this as well. And I do this in clinical practice when it comes to dietary change, which is one of the biggest things we can do positively, but one of the hardest things for a person to try to do because it feels like such an uphill climb. That I always say, we're going to start with, we're going to get along well. I always say, we're going to start with sleep. That's the number one, because that's like the lowest barrier to success, I think. But then as we start to kind of build up and we talk about diet changes, I say, you don't have to make this whole new shift like on day one. We're going to start by, saying we're going to only eat animal meat one time a day. And if you do that, you're going to suddenly have to start incorporating more fruits and vegetables. And we're going to start to cut out some of the processed foods. And we're going to cut out, alcohol and marijuana and things that maybe we don't need that we've just normalized, and try to make it not seem like I have to just change every single thing in my life, because that, especially without education about why, becomes really hard. And when it comes to fertility factors in general, there's such a loss of control on here that I find that people are really willing and desire to do what they can to have a higher chance of feeling better, of having better outcomes, of having an easier time. So I find that patients are really highly receptive to it. And I'm glad that we're having this discussion, on a bigger scale. I'll say often, I wish fertility was approached like other things. I wish we had a more proactive approach. I mean, it's a life goal for the majority of people
Mhm.
that we don't even think about until you're starting. And because infertility used to be less common, it was very acceptable to say you have to fail first, right? The whole field exists as a response to failure. Oh, you didn't get pregnant after trying for 12 months. So now you can go have your testing done to see if something is wrong. And I really think that's an antiquated response. I mean, it's how my whole field is. I get it. But when we see infertility rates are rising, more people struggling to get pregnant, yet people still want to have children, we should start to have these discussions much earlier, especially when we see that these different foundational choices are impacting their ability to get pregnant. When we see an increase in male factor fertility, why are we not doing a semen analysis earlier? And that's my big lofty goal with the book, is really to change how we approach our fertility in general and trying to make it a more proactive approach versus reactive, which is what it is now.
Hmm. It definitely feels reactive. I mean, I think of just, going back when I was a teenager, learning about my body and my cycle, and just how there's a lot of, maybe shame or, oh, we don't talk about that. And then even having like young adult males that don't recognize that a female can't get pregnant every day of the month, and just like this basic foundation knowledge. Um, on the inflammation part, I'm at this age where I'm getting these Instagram targeted ads for fertility vitamins
Yep.
and
And
perimenopause.
perimenopause at the same time, right?
No, wait, I don't know if I love this age I'm at right now. So I don't know. I'm kind of a tweener is where I'm at. What are your thoughts on, like, what are those concrete things, like taking this supplement, make sure you're getting more iron, vitamin, what would that recommendation be? That's
I think I think we always have to say, like, one is that we're all individual and a personalized approach is always going to be best. That being said, there are some commonalities that most people are going to benefit from. And we would love it if we got all of our nutrients from our diet, but that's not reality for most people. When it comes to vitamins and supplements, and let's just say we're at the stage of life that we are maybe done with our family, yet we're still having cycles and we're kind of in this, loose, we'll say perimenopause or post children kind of time frame. We really need to look at this as some really important years for women in their reproductive life, because once your ovaries stop functioning and they're not making hormones anymore, you're going to start to be on this decline time frame where you'll have to choose if you want to take hormone replacement therapy. But we know that that lack of estrogen is going to be impactful for bone health, for muscular health and strength, for brain health. And so viewing this time period where I'm not giving myself towards, being pregnant and nutrients for, nourishing a pregnancy. This is my kind of last big period of life to prepare myself for the menopausal transition, which is going to be hugely impactful no matter what. And so this is going to be, from a supplement standpoint, omega-3 fatty acids for everybody for brain health. We want to see more vitamin D and calcium for bone health. For a lot of us, we do tend to have increased inflammation at this stage. So I like magnesium for a lot of people, and I like CoQ10. And that's kind of my, like, most people are going to need these slash benefit from them and not find harm in taking those supplements. We also want to say this is a really important time to think about, the best exercise for hormonal health, no matter your age, is actually strength and resistance training. And this is because building and using skeletal muscle is one of the best things we can do for our hormonal health. For the lack of, like, going into nitty gritty, although we absolutely can, when you have skeletal muscle, you're able to use up your glucose without needing insulin. And it's a way to decrease inflammation by having that skeletal muscle and using it. We know that building skeletal muscle, that, protecting your health later is going to be a lot harder after menopause. And I also think this is just an era, generation of women who we viewed exercise as, like, to look a certain way, to be a certain thinness. And it wasn't, let's go lift weights and build up strength and have good hormonal health. It was to be a certain size and to do a certain type of activity for that. So we have a generation of women who didn't lift weights, who didn't build up muscles, who used exercise to be thinner, which was ultimately can be harmful to our bone health as well. So I think that in the same kind of breath where we say, this is when we should be working on our gut health. So lots of fiber, Eve, lots of fruits and vegetables, really looking at, healing up our, gut integrity, which is less processed foods, more whole foods. Those good foundational habits, right? The sleep, stress, and exercise, the supplementing the extra things that we need for bone health and to decrease inflammation. And really looking at kind of getting our muscular strength up to a great place so that when we enter the menopausal transition, we're up to speed. We're not in a deficit, which is what we're seeing right now is a generation of women entering menopause already in a deficit.
Gotcha. I'm assuming men don't get this complicated with it for their
Well,
hormone health.
men don't. I mean, men do go through a menopause, for lack of a better
Mano?
word. I mean, the testes
Yeah.
do. They do stop making
That's amazing.
testosterone at some
Yeah.
point, and it does impact, their health as well. But it's so significantly later than when women
Mm,
are going through that it's not the same level of impact. Really, we're looking at the age people live right now. And when you go through menopause, I mean, this is going to be almost half your life where you're going to be living it in menopause. And, the human body didn't used to live this long. So, now we're at a place which is great. We've improved longevity for a variety of different reasons, but especially for women, we haven't improved health span, right? Living healthy, being able to be active, both mentally and physically active. We know that, hip fractures in older women have a huge mortality rate. And so a lot of this is kind of now flipping that discussion is not, we don't want to just live long. We want to live long and prosper and be healthy and be active and have a lot of vitality. And for women specifically, we have to really have a proactive plan for that.
hmm
Natalie, are you all seeing any differences in fertility rates with GLP-1s being used more widely with glucose levels and et cetera?
Yeah, I see it. I see a lot of patients who, right now, if you're on GLP-1s, the recommendation is to be off of a GLP-1 for 2 months before you get pregnant. And that is just due to fear of, fetal implication from the medication. I will say, I think that that is a very conservative recommendation because we certainly have patients who are on them who get pregnant. And there's been, people have looked at this and there haven't been any negative outcomes, but as that's the official medical recommendation. What I will say is I'll have a lot of patients because they can't do them and active fertility treatments kind of say, I'm going to take a break. I'm going to take a break. I'm going to work. What should I do? And I say, we should decrease inflammation. So we kind of talk through. And a lot of times we're making lifestyle changes and they're incorporating a GLP-1. And these people are either getting pregnant while they're on the medication or they're coming back and having a different outcome, right? So we did an IVF cycle. We didn't get any normal embryos. What are we going to do? We say, hey, we can't just do the same thing. We need to go make some changes. What are we going to change? We're going to try to bring some different eggs and sperm to the lab. So we take a few months off, they're making these changes, and then we see a completely different outcome where we now have, much better embryos coming through the lab. And I think that there's probably multiple reasons, right? Like decreasing your body weight decreases inflammation, but also like these medications directly increase inflammation. They change how we eat. We become more insulin sensitive. And then when people start to lose weight, they are more interested in suddenly lifting weights. And so I think that it's not one magic thing, just this GLP-1, but for so many people, it's the catalyst to a
hmm
multitude of changes that are all beneficial when it comes to inflammation.
Can we talk a little bit about the polarization and hot topic of hormone replacement therapy? And if
Yeah.
you are a woman listening to this podcast, I think a lot of people are like, well, my mom had to suffer through perimenopause and menopause because she was told that hormone replacement therapy increases the risk of breast cancer. And so you're just going to have to deal with the side effects. And you mentioned, I mean, let's like quality of life, bone density, et cetera. So can you talk a little bit about hormone replacement therapy and why maybe things are viewed differently in 2025 than what they were in the recent past?
Absolutely. So this is a great question, especially for just, the general public to kind of understand is that there was a big study come out that was called the Women's Health Initiative, and it was looking at hormone replacement therapy to try to see if it was good, if it was bad, if there were, negative consequences from it. One of the big things that happened in this study is that there were different groups of women. Some were on estrogen and progesterone, some were on just estrogen. But these women were significantly older and had been through natural menopause, most of them for over 10 years. So their body had adjusted to a new normal state, not having hormones. And then they went and reintroduced this hormone replacement therapy. And early analysis stopped kind of these studies early due to some of these concerns. And one of the main ones was the increased risk of breast cancer. Even on reanalysis now, it looks like the data is different, especially depending on the group that you're looking at and looking at confounding variables. One thing I'll say here that I also think is really important is that for a long time, many people have been still advocating for hormone replacement therapy, just done in the right way, but it is so much nuance and confusion for patients. we know for women in general, being low estrogen will shorten your lifespan. It will it'll change your quality of life, increase your risk for dementia, increase osteoporosis. I think it's important to say this isn't just post-menopause. I see so many women who are low estrogen because they're not having periods, they have hypothalamic amenorrhea, which means maybe they were on a diet trying to look a certain size, they were not ovulating, they weren't trying to get pregnant. Nobody said your period's actually important. And they're like, I don't have a period, but it's no big deal. I'm skinny. I'm happy with it. And they went through not having estrogen for a lot of critical years also that can also increase these risks. And so we've been putting women on, hormone replacement, at a variety of different life stages. And for some women, they go into menopause early. And we've been a huge advocates of those hormones. So we used to say, oh, if you went into premature menopause, we'd put you on hormone replacement until the natural age of menopause, 51, 52, and then you can kind of make a good decision. What we're seeing now is that, especially if hormone replacement therapy has started proximal to when you're going through menopause, seems like there's very little risk from it in the average person. If you have a cancer risk in your family, we've even seen that you can still qualify for hormone replacement therapy. We just might want to change the method or the preparation. So this is a good example where vaginal estrogen is a great option because traditional dosing of vaginal estrogen isn't as systemically absorbed as oral estrogen is. There's a lot of different options and choices. A big kind of universal kind of truth is that if you have a uterus, you need estrogen and progesterone. We can't give you what's called unopposed estrogen because it can increase the risk of uterine cancer, and that is well demonstrated and known. But this universal increase of breast cancer has actually been disproven. And, I have a mom who's in this category as well. She actually went through surgical menopause, had her ovaries removed when she had a hysterectomy, was told that it was too dangerous to be on hormone replacement therapy, suffered for many, many years, and I finally convinced her, like, I think that the risk benefit here doesn't make sense and we should kind of get you on something. And now we're seeing kind of a whole transition over there, which I think ultimately people deserve to make a choice that's right for them. And I'm not here to universally say this is the right choice. As an REI, most of us really love estrogen and love hormone replacement therapy because we see so many patients who are without estrogen, and we know how profoundly that impacts the female brain. That being aside, what I don't want people doing is not choosing an option or not feeling like an option exists out of fear alone without understanding it. And that is what happened to a generation of women. So we're at a place now where if you are universally told hormone replacement therapy is bad, you need to go get another opinion, right? Maybe you're not a great candidate for it for a certain reason, and you should be explained, this might not be great for you because of X, Y, and Z, or potentially you have this clotting disorder and I'm fearful of this, so I want to use a different preparation. But this is an, educated decision so you can make an informed choice. And whenever women are being told it's one way for everybody, this is always the outcome, that's a big red flag because that's really, that's not great care. That's not reality in medicine. We don't have all the answers. And at the end of the day, it's your life, your health. People make choices that might carry certain risks, but for quality of life, it might make sense to them. And you deserve to be the one to make those choices for you. And I think that was the longest answer to that very simple question that I
Great
could have
answer.
given you.
Well, I knew
It was great.
it wasn't a simple question. And I really appreciate you walking us and the audience through that because that was super helpful and enlightening. Thank you.
I think a lot of our listeners are mothers, and they're either juggling teens, young children, or young adults, but they're also facing perimenopause or menopausal symptoms. And so they're in this kind of double chapter of nurturing others while trying to relearn their body, but how do you navigate it? Can you kind of define and tell us the difference? Like, what are those signs and symptoms of perimenopause? What is abnormal? What's normal? Like, what's kind of the trajectory of that? Because I have moms coming all the time and they're like, I'm 40, I hit 40, my give-a-damn's busted, I have no patience. And it's like, well, it could be your
Yeah.
kids or it could be you.
Uh, This is so hard in highlighting that when you're on, it's what has happened to the majority of people in this age range you're talking about, and I'm one of them. You're on birth control for the majority of your reproductive years. You stop it when you try to get pregnant. You go through these series of, pregnancies, postpartum, crazy hormonal changes. And then suddenly maybe you're on the other end of it and you don't want to go on birth control anymore. But you now for the first time are experiencing cycles. You never learned how to track your cycle. We're not giving the tools to really understand what should have been normal a long time ago. So we're then in this huge deficit as saying, is this normal? Is this how you feel when you have progesterone, or is this abnormal? And I don't know what to do about it. So I'm hopeful that we see a new generation of, women approach this. And I'll say, as somebody who has a daughter going through puberty, the conversations we have talking about our bodies, about perimenopause, about our cycles can be so impactful for the younger generation to feel normalized talking about their own bodies and talking about what's going to be happening with their own menstrual cycle. Because we did live in a world of a lot of stigma and shame. Like, my period's bad. Everybody's must be bad. I just must not tolerate it well. It's such a common sentiment versus saying, when you have a period, you shouldn't bleed through your clothes. It should come every month. If the pain is so bad that you want to stay home from school, that could be a problem. And you should feel free to tell me those things, right? Those discussions weren't had in my house. I don't think most of my friends had those in their houses as well. When it comes to perimenopause, here's going to be my very simple explanation, if we can. Our eggs are in our body our whole life. I like to think about them as in a vault inside our ovary. And every single month, a group of eggs comes out of this vault. And that actually happens well before our first period starts. So eggs are coming out of our vault every single month. What's very fascinating is when the vault is more full, we're younger, more eggs come out every month. And as we start to get older, fewer eggs come out every single month. Well, all the time period before puberty, eggs were coming out of the vault, just nothing happened because puberty is the brain activation and the brain turning on. Once you go through puberty and the brain turns on and starts really sending out the hormones FSH and LH, that's what's going to get you to grow an egg and then to ovulate. So now from this group of eggs sent out of the vault, one of them will be chosen to ovulate, the rest of them die, and then next month another group comes out. This process has issues at high end of egg counts and low end of egg counts because the brain can't see what's happening inside the ovary. So it actually has no idea how many eggs are outside the vault. It's starting by sending out its little regular amount of FSH. So if you kind of fall into the perfect zone, great, an egg grows, ovulates at a predictable time. You kind of have a set luteal phase after ovulation, and then the process starts over. Well, let's kind of lead into what starts to happen in perimenopause. You start to reach a critical threshold where the eggs in the vault are less. So fewer eggs come out of the vault then. The brain doesn't know this, sends out its normal amount of FSH. And what first starts to happen is that's a stronger signal to each individual egg. If you now have 8 eggs outside the vault instead of 18, they're all getting a stronger signal and you're going to start to ovulate faster. This means that you have less days of estrogen-only days. You're going to ovulate sooner. You also don't start to have the best corpus luteum. What that cyst after ovulation comes from the follicle. And so then you start to have kind of some spotting that might happen before your period and your cycle starts to shorten. So most women, if they know how to track their cycle, will start to say, my periods used to be 29, 30 days, but now they're actually like 25, 26. Is that normal? And a lot of people will say, if they're coming regularly, it's totally normal, no big deal. But that shift alone, I would say, oh, your egg count's dropping. Okay. You're then going to start to have some irregular hormone production as this number is coming out of the vault because the vault's not perfect. So, oh, you had 8. Well, what happens next month if you have 6? What about the month after that when you have 12? And you start to get where it's so unpredictable month to month. You might still be having periods, but they're subtly different. So if you learn to track your cycle, you can start to see and anticipate some of these changes. But when you have on the big whole, because estrogen's our favorite hormone, when we have fewer estrogen only days, you're going to start to feel less good. And then as we get closer to menopause and the vault's even getting emptier, so now you have only 4 eggs sent out of the vault. Well, now the brain is sending out its FSH. But what happens when we go into menopause at ovarian failure? The ovary doesn't have any more eggs to give, right? It goes into failure where it won't respond. So you start to go into this transition period where say the ovary's like, I really don't want to lose any eggs. I don't want to let any grow. And then the brain has to send out an even stronger signal of FSH to get an egg to grow. Now your period starts spacing out because instead of ovulating early, now it's taking you a while. The ovary's stubborn. It's taking it a while to respond to that FSH. The brain is sending more. And this is when women really start to notice it because they say, I didn't have a cycle this month. Or I'm getting some hot flashes from all these low estrogen days, or I'm having some low libido and vaginal dryness. But really, if we start to notice that these perimenopause changes are actually happening back here when we're still having monthly cycles, if we're learning to capitalize on those, we can optimize how we're feeling. And then we're not like in such a big transition state when we're kind of going through this next state where our cycles are starting to get sporadically out. But that is telling us that we're now starting to enter a time period where menopause is going to be coming imminently. And if we know this and we recognize it, we can then start to think about these questions. Do we want to take hormone therapy? When do we start hormone replacement therapy? Because a lot of women can benefit from it when they're actually starting to have these low estrogen days in these cycles that are starting to space out. So you can bring in some really low dose estrogen if we think about it. So you're not kind of bottoming out on these days as you're waiting for that ovulation to kick off. And that can start to be an easy way where you can feel better if women are starting to feel low estrogen symptoms, which can be fatigue, difficulty sleeping, hot flashes, low libido, vaginal dryness, an increase in UTIs. Like, so you start to really say, like, I don't feel like myself. I feel like I have low energy. I feel brain fog and difficulty concentrating. That is often a time where women wait, not because it's women's fault, but because it's how medicine is designed right now. Menopause is defined as once you've not had a period for a year. So if we wait to start hormone therapy until you're in diagnosed menopause, you now had to be, by definition, estrogen deficient for an entire year when you didn't have a period before we will now start menopausal hormone replacement therapy. Because if that's kind of my criteria to get you into hormone treatment, you now had to suffer before we would do that. So I do think we're seeing an enlightening where people are seeing more talk about perimenopause, more talk about menopause, but it can be really hard to get care. I tell a lot of patients, like, not all, this goes universally, right? Not all doctors are created equal. So it's not about demanding one thing, but it's about having a provider who you can have a honest conversation with and understand. But a lot of this is from you as well. You have to give a good menstrual history. You have to know what symptoms are bothering you. You've got to come to the table prepared with the information, because as a doctor, I can only work with the information you're giving me. Like, I don't live your life. I don't know what's happening. So you've got to come to the table saying, hey, here's what things used to be. Here's what they are now. These are the things that are bothering me. What can we do about it? And that's going to be a way to advocate for your health that's going to be much more successful than just saying, I don't feel good, I don't know what it is. Because I believe you don't feel good. But unless we can kind of start to, pick which things we don't feel good and what's happening, it's going to be really hard for us to have an idea of what to do about it.
Natalie, on the psychological side of things, some of the women that struggle with fertility and loss, it's really the deepest depths of kind of despair and hopelessness. Sitting with your patients and working with them, what do their male partners need to know based on your interactions with your patients? I'm curious to know what the men in the room need to know.
I think that's a great question. And I've seen a huge, we've changed how our practice functions, and I've also seen a huge change in some of my patients. So I will say this. One of the best things COVID did for the fertility industry was allow us to transition to telemedicine. And our practice still uses telemedicine for new patient visits. And I will say, I'll scream this time blue in the face. The number one thing you can do as a male partner, if your female partner is going through infertility, is be present. And that includes being on appointments. Because what happens right now is that if the female's at the appointment herself, she's going to hear bad news, lots of statistics, a game plan, and it costs money. And then she is solely responsible for relaying that information back to you. And then you might have questions that she doesn't have the answers to. And you're putting your partner in a place of vulnerability instead of being a support person. So if there's an appointment you could get with me tomorrow, or an appointment you could get with me in 2 weeks, but your partner could be there in 2 weeks, take the appointment in 2 weeks. Like, have set up for success from both ends. Because if your partner can be present, what I find is that the journey is mentally and physically and stress like a lot easier because you get the support. You no longer, as the female partner, have to be advocating for your health as strong, because, well, he can hear everything too, and he understands the situation you're in. You can make this decision as a team. He can ask his own questions. He can hear some of these facts, like how cannabis is one of the top things that's decreasing sperm counts, increasing miscarriage rates, and that, that nightly habit that he says is not so bad because every friend does it, is actually impacting, your fertility journey. And you don't have to be the nagging partner who's, bothering him about that. You can let me be the bad guy. So I think that's the number one thing is being present when you can. And I understand we can't always be present, but I'll let guys, call in, go on speaker. If you're at work and you can't physically talk, just, listen to the call, just hear the information so that you guys can then talk about it at home later. And you're not just saying, what did the fertility doctor say? And that goes for a lot of these appointments because it is nothing's going to make you question like who you are, what your future is going to look like as one of your life goals being challenged, like the possibility of not having a child that you want to have. So I think this is such a loss of, sense of self that it's really important that, as a partner, you're there along the way to make those decisions. You're supporting with your presence. And then also these lifestyle stuff, all this inflammation, that impacts men and sperm just as much, if not more, than women, because the sperm lifespan is 90 days. So we can make a change and see a hugely different outcome, in a few months from now. And for women, our eggs are inside our body our whole life. We can still make an impactful change because they're most sensitive as they get closer to ovulation. But that delta, the different change that we can make for men is even more so. So it's a team sport. Like, let's approach it as a sport. Let's make these lifestyle changes together. Let's, be on these appointments together so that we're both working towards this goal.
Those
As
changes,
people
Natalie,
are
would be, sorry, Eve, I'm talking a lot because I'm super fascinated. Natalie, those changes for men would be sleep, exercise, diet, decrease cannabis use. What else?
Yeah, decrease in alcohol use as well, smoking cigarettes, vaping. And then for men specifically that women don't have is going to be external heat sources to the testes. So sauna use, which is so big and trendy right now, hot tub use. And then if we are like, if we laptop on lap, if we actually have external laptop heat on the testes or prolonged cycling. I'm in Austin, so I do see some guys that are really heavy cyclists and the compression on the testes for that, we're outdoors cycling for 2 hours a time, multiple times a week, that can increase that testicular temperature. And I always say the testes are outside the body for a reason. They need to be at a lower body temp.
Eve, all yours. I'm quiet.
Well, you said something that kind of reminded me that, people are waiting later to have kids, right?
Yeah.
And so do you find yourself kind of having that conversation like, oh, we're looking at an overlap of perimenopause and fertility?
Oh, absolutely. I always say there's this perimenopause discussion, and I'm really good friends with Mary Claire Haver, who's like the menopause queen. And I always say, I've been talking about perimenopause for a decade. I just call it diminished ovarian reserve or low ovarian reserve. It's just women who are starting to have a lower egg count who are still wanting to get pregnant because, I have probably the bulk of my patients are age 38 to 45, which is, when perimenopause is starting to hit a lot of people. So I think, the high points here is that women are waiting longer to get pregnant for a multitude of different reasons. We're finding partners later. There's career goals. There's, simply just not being ready, variety of reasons. We see infertility rates rising even independent of that, right? So we kind of can say this is going to make it harder because age-related fertility changes are real. Your ovaries are in your body your whole life. That means it's even more important to try to take charge of these factors we can, right? To know your cycles, to be making each month count even better by knowing how to track your cycles, by if you've got a red flag problem, going and getting that evaluated sooner, by not waiting as long for initial testing. And I'm a huge advocate for women who are 38 and older, getting, fertility testing before you're even trying to get pregnant. Like get a semen analysis, get your ovarian reserve tested. Why wait to fail before you get an evaluation when you kind of don't have as much time? And this is especially true if we're having cycle abnormalities and that perimenopause transition or that, because that's a sign of a low egg count, which means that you're going to have, potentially a harder time getting pregnant, maybe get fewer eggs, even if we're doing IVF. You may not have as much time to fulfill your family goals. What if you're just starting for your first kid and you're 39, but you want more than one? These are conversations that we really do need to be having. And this old idea of I'll try for a year and then I'll see a fertility doctor and then we'll kind of decide what to do. I don't think it really applies to a lot of people. We say if we're starting our family later and you want more than one kid, come see me now. Let's do testing. Let's make a game plan. And, you know, I love that switch, this idea of I'm going to wait for my OB to tell me I need to go, or I'm going to wait a little bit longer. You don't have to do that. You can actually call, a fertility doctor's clinic right now and say, "Hey, I'd like an appointment. I want to get some testing done and talk to somebody." And we can do that. So I do love that we're seeing kind of that switch, but it comes from the patient. So if we're just waiting, being a
Hmm.
passive member saying, "I'm sure my OB will tell me if I need to go see a fertility doctor," you're probably going to end up waiting too long.
Well, I like that you're hitting on that self-advocacy piece because I know it's, from my own personal experience with some doctors, there's not always space for that. So it can be hard to self-advocate, especially when you don't have the language to dialogue about it. How do you think that women can advocate for themselves?
It is a really great question. I think the first thing we have to do is, improve fund of knowledge, because you can't advocate for something that you don't recognize as abnormal. I just had a podcast episode go live, and in the comments, you'll see all these people say, "Is an irregular cycle abnormal? Or do I need to get help for that?" And something as, what we consider foundational knowledge, so many people lack. So starting by saying, "I deserve to understand how my body works, therefore I can know what's normal." Because if I know what's normal, I can start to recognize what's abnormal. Second is to say that you have to understand when to advocate and how to do it. So, one of the biggest failures I see for women specifically is they're trying to advocate for their health at their annual exam. And that's not what an annual exam's for. That is a 15-minute visit for a pap smear and preventive care. So, your doctor has a list of things they need to go over with you and talk to you about. And if you come and say, "Wait, but I really wanted to talk about, my heavy periods," there's not time in that visit, nor are they prepared to discuss this. So when
I
you
didn't know that. Sorry,
Yeah.
Dr. Denard.
No, but so when you recognize one of these problems, so you say, "Okay, well now I know what's normal, so I can say I'm bleeding through my clothes and that's not normal. I'm going to go schedule a problem visit." So you're going to call your doctor and say, "I need a problem visit. I'm bleeding through my clothes." You're going to then get, 20 plus minutes of just talking about your bleeding through your clothes. And this is now your doctor now has the time to approach this as a problem focused visit. You also need to, as we said earlier, think through what all is going on, how long it's been happening, what's been happening. So you can give a good story. We're all historians, and it's in medicine, we'll say, "Oh, they're a good historian or a bad historian." So coming in with knowing your own history is going to help your doctor figure out what tests to do, because that's what we do. We hear your story, we ask questions to clarify, and then we decide these are the tests I want to run because these are the potential things I'm thinking can be going on. But if every question I ask, you're like, "Oh gosh, I don't know," or "I haven't thought about that," or "Gosh, I have that on paper and that's at home," then you're setting yourself up for a disservice, because I don't have the information I need to order the right test to get you the diagnosis you deserve. So schedule a problem specific visit. Think through what's been going on, how long it's been happening, if this has changed from before, and write it down, because it can be really overwhelming in the doctor's office. So,
Hmm.
write it all down. If you have specific questions, write them down as well. And so then when we come in, we say, "Hey, I see we have a visit for heavy bleeding. What's going on?" Your first moment at most doctors is like, I give my patients the floor. I say, "Hey, I see we're doing this, but like, tell me what's happening." So that's your moment to say, "Okay, for the past 6 months, I've noticed I've been," and kind of being able to give your story. That's one of the most powerful things that people don't leverage enough. They try to squeeze in their
Hmm.
little visit, like, "I'm going to my doctor in 2 months. I'll just squeeze in my heavy bleeding at that time." And then they're left disappointed because their doctor didn't have time to address it. They weren't prepared for that. And then the patient themselves didn't spend the time to think through those questions either. And the last thing I'll
Hmm.
say is there are absolutely, bad doctors, bad clinics out there. And so you are not married to one doctor or one clinic. It is a relationship, and I tell my patients this too. If I'm not giving you what you need from the relationship, go find somebody else. Like, you deserve that. You need to know that your health is being entrusted to somebody that you trust. I never expected that the hardest part of my job would be to get people to trust that I had their best interests in mind, but that is modern medicine in this political climate. So
Hmm.
if you don't trust this doctor, there's a variety of reasons. If you feel dismissed, if you guys have a different communication style, if the nurses, they always call in there's a variety of different things that go into that. Go get another opinion and go seek somebody
Hmm.
else, because that shouldn't be a part of your healthcare, is questioning if your doctor has your best interests in mind. And if that is the case, then you deserve to say, "You know what, I'm going to send my records somewhere else and go see if I can get a better fit."
Hmm. That's super helpful. Where can our listeners find you?
Well, thank you guys. Listeners can find me a few different places. So online, I'm on Instagram at Natalie Crawford MD, and my clinical practice in Austin is called Fora Fertility. That's Fora. And I host the As a Woman podcast. And my new book is called The Fertility Formula, which is available for pre-order at nataliecrawfordmd.com/book or anywhere that books can be found.
And when will it be here?
Yeah, it's for pre-order right now. The book will be released in April of 2026. And if people pre-order it now, we do have some bonuses that go along with it. So there's some, hormone guides, there's an IVF course, and then we're doing a monthly book club where there's some modules released that tie in with the book, and we're doing Q&A calls. So if you're really wanting to learn more about your hormonal health and want to dive into the content sooner than April, then come on and join.
That's awesome. Well, thank you so much for coming on today and for reminding us that understanding our bodies is one of the most empowering things that we can do. The fertility formula is such a great gift to women everywhere, and for those who are thinking about pregnancy, to those navigating the hormonal shifts of perimenopause. Thank you so much for coming on today.
Oh, thank you guys so much for having me.